Hello, thank you all for joining us today. I'm Heather DeMoss, and I'm the Clinical Operations Manager at Clarity PSO. A little bit about me. I'm a nurse by training with experience in emergency and surgical nursing, and I'll be moderating today's discussion alongside some of my other colleagues here at Clarity, including Tom Piotrowski, who is actually the Executive Director of Clarity PSO and Vice President of Clinical Operations. Tom is also a nurse by training and has over 15 years of healthcare experience in various settings. He has developed quality safety programs from a variety of healthcare providers across the country and is actually a national speaker with a significant emphasis on leadership, patient safety, and healthcare culture. But before we introduce our speakers and dive into today's content, I'll just mention a few housekeeping items. So firstly, you are all currently on mute, but we'd really like this webinar to be more conversational and discussion-based. So we'd also like to keep it easy for everyone to hear, but also really contribute to the conversation. So we ask that you all please utilize the raise the hand feature, which is just an icon of a hand, and it's located within the GoToWebinar toolbar on each of your screens there. When you actually click that icon, we will then unmute you on our side, and you'll be able to ask your questions or provide any comments that you may have. We're also opening up that chat box function, so you can also write a comment or a question in there, and we'll also keep track of those conversations happening. Secondly, this webinar will be recorded, and a handout will actually be provided after the webinar upon request. And you'll have some information on who to contact at the end of the webinar. And now I actually have the honor to introduce our three panelists for today's webinar. Firstly, we have Heather Annalino, who provides healthcare consulting services for physicians, nurses, medical group practices, hospitals, critical access hospitals, long-term care facilities, and other healthcare providers here at Clarity. Heather has over 20 years of experience in the healthcare industry and 15 years in risk management. Her clinical experience was primarily focused on pediatrics and emergency nursing, and she has many years of management experience in both the emergency department and risk management. Heather received a Bachelor of Science in Nursing from the University of Wisconsin-Madison and a Master of Business Administration from DePaul University in Chicago. She is a certified professional in healthcare risk management and is a current member of the American Society for Healthcare Risk Management and the Chicagoland Healthcare Risk Management Society. Our second panelist is actually Dr. Barbara Brannon. She earned her pharm degree from the University of Maryland School of Pharmacy. She has worked at the University of Maryland Medical Center for over 20 years in many different roles. She has been the Director of Pharmacy there since 2013, and before that she was Assistant Director for Quality and Education. Dr. Brannon is also a clinical assistant professor at the University of Maryland School of Pharmacy and is adjunct clinical professor at Notre Dame of Maryland School of Pharmacy. She has participated as a Healthcare Advisory Council member for Clarity PSO since 2009. Dr. Brannon has a deep understanding of the medication challenges facing hospitals and other healthcare entities. She has presented locally and nationally on topics relating to medication safety, regulatory compliance, narcotic diversion, and others. Our third panelist is Dr. David Seidler. He actually earned his medical degree from the University of Illinois School of Medicine and specialized in emergency medicine. He has worked at Charleston Area Medical Center for over 30 years in various positions, such as Chief of Emergency Medicine to Medical Director for the Department of Emergency Medicine, and most recently, Director of Clinical Integration and Technology. He is on several committees, including the Healthcare Advisory Council for Clarity PSO since 2009 as well. Dr. Seidler is a national speaker and has a wealth of insight regarding patient safety and the challenges healthcare organizations are facing. He has worked alongside his colleagues at CAMC and with various organizations on a multitude of improvement projects. Thank you, Heather, Dr. Brannon, and Dr. Seidler for joining us today. And now I'd like to turn it over to Heather Annalino to set the stage for us.
Good morning and good afternoon, everybody. I'm very glad to see all of you here, and just want to reiterate, we want this to be interactive. So please go ahead and use the chat function or raise your hand as we progress through our discussion today. Just to sort of lay the land on and have us all on the same page about, sort of where we are with the opioid epidemic. Back in 2009, that's when the warnings began, actually, of the possibility of addiction to opioids. It wasn't necessarily widely discussed or, really talked about at that point, but the American Pain Society and the American Academy of Pain were already aware that there were issues and concerns. They had seen an increase of acceptance of the drug to relieve chronic non-cancer pain, which was the goal, but at the same time, they had concerns about prescription opioid abuse, addiction, and diversion. So we all know, though, that opioids are valuable drugs and they are necessary. On average, 91 people die each day from abuse in the U.S., and the number of deaths has quadrupled since 1999. And the gap is closing even when you look at it economically, or even socioeconomic or geography. It used to be that the overdose deaths in the rural area might have actually been higher, and now that gap is closing between the rural and the metro areas. This is an epidemic that crosses all levels of society, with over 5,000 overdose deaths and 3,000 actually tested positive for fentanyl, and 700 for fentanyl analogs such as carfentanil. So we're getting beyond the hydrocodone and Vicodin and some of the other pieces that we're used to seeing. This is growing rapidly into the synthetic uses as well. And as we all know, that oftentimes our prescribers don't know the patients are seeing multiple people, and there's duplication in their prescriptions. And when you look at where the highest prescribers are, family physicians are writing about 15 million prescriptions, or probably even higher today. And internal medicine wrote nearly 13 million. So that adds up to more than half of all the prescriptions written that year. 60% of these deaths occur in patients that are issued prescriptions based on the guidelines that the medical boards had originally set forth. So it wasn't as if people weren't necessarily following the guidelines that were out there. And then 55% of people who abuse prescription painkillers, they get them from their friends. It's actually not necessarily as high from the physician side. Only about 17% obtained through a physician's prescription. But these are the folks who have it in their cabinet and are either offering up to friends or family, or even the teenagers may be finding it and using it themselves. The prescription drug monitoring programs, and we'll touch more on this, but I wanted to give an update on this. That there's been a big change and a big push in making these accessible and useful. So they're in 49 states, the District of Columbia and U.S. Territory Guam. And every state except Missouri has created a statewide database. And the reason Missouri doesn't have one is because they feel that it's somehow breaching patient confidentiality if they were to put this information into that system. 16 states have actual drug monitoring laws now that require doctors to consult this PDMP before they prescribe any opioid painkillers. 29 states have mandatory access provisions. It really varies state, by statute, by rule, by board policy, whether there's a mandated query necessary for the PDMP. Now, New York has shown a 75% drop in patients who are seeing multiple physicians for a large amount of drugs since they implemented that they were required to look at the PDMP. 25 states in the District of Columbia as of 2015 actually are providing immunity from civil actions to practitioners for accessing or not accessing that information in the database. And I think that's, a very interesting point that I wanted to make here. So we all know that the amount of prescriptions, even in 2015, was enough to medicate every person 24/7 for 2 weeks around the country. That's how much we're giving out right now. And considering when you look at what the crisis, what sort of has escalated it, it's probably a combination of so many things. This makes this very complex for us to address. Lack of awareness, misinformation, misperceptions, misinterpretation. This epidemic now spans so that each and every one of us probably knows someone within our family and friends who's been touched by an opioid disorder or opioid event. This is going across your ethnicity, age, geography, socioeconomic status. I mean, it's really to the point where none of us are going to remain untouched by knowing someone who's encountered an issue. And that's what brought us, here today, and why we wanted to put this panel together. We talk a lot about here are the guidelines and the toolkits, and why don't we put these into place? But we wanted to have a discussion that really brought together the challenges we're facing, what providers are doing to try to address that, and sort of what are some of the new challenges that are arising because of this. So today we have Barbara, who's our pharmacist, and Dr. Seidler in emergency medicine, and myself to have a discussion about what we're seeing since some of these things have started to be implemented. And I think what we'll start with is, what are the biggest challenges that come to mind for you now that you've started along this path? And I'm going to start with asking Barbara to address that question.
Thank you, Heather. So it's taken us a while to get to this point. Certainly, society has to change their culture. I think people expect their pain to be treated effectively. They don't want to experience any pain. So I think we have to change patients' expectations of pain management, and they have to realize that, yes, they will experience pain, and we have to try to work with them to manage that appropriately with the lowest dose of medication, particularly including the non-opioid pain medications and other non-pharmacologic modalities first before going to the opioids as a first line, especially in patients who are opioid naive. Heather mentioned there's a lot of laws and regulations, so trying to work through those is a challenge, especially when the managed care organizations have different requirements. So it's not even like all of the patients in, let's say, my state of Maryland have the same requirements. It depends on their payer in terms of what prior authorizations are required, how many opioid tablets of oxycodone they can get per month, or other drug in terms of the morphine milligram equivalents, and which patients are mandated naloxone prescriptions in conjunction with their opioids, and how to fund these for patients who can't pay. So all of these are challenges that are being addressed now with the new laws and regulations. I'm interested to hear how other people are managing this, because I know we're all facing the same issues. Might be slightly different across states, but they're very similar.
Mm-hmm.
If anyone would like to comment, please let us know. Otherwise, I'm going to turn this over to Dave and let him point out what he's seeing from his area of specialty.
Well, of course, I agree with everything Barbara mentioned, but we are seeing some significant changes because of the laws. West Virginia is one of the states with mandatory checking of the database, and we are seeing a significant decrease in opiate prescribing, but that is generating in many ways, a bigger problem, which is a switch from a prescription opiate use to the use of illicit IV opiates, particularly in our area, a lot of heroin use, a fair amount of fentanyl use, where large quantities of fentanyl are coming in through Mexico and China. And that is spawning even bigger challenges, because we're seeing actually increasing overdose rates, increasing deaths per year. We're probably going to see 1,000 deaths in West Virginia associated with opiates this year. So while the laws are working in a sense, it's just creating a different pocket of opiate abuse, and the lack of treatment programs is pretty remarkable. So we have this huge population of of opiate addicts that's kind of are over many age groups. It's not just the young adults, and we have nowhere to point to for treatment for these patients.
That's really interesting that you actually point out the fact, Dave, that we do have a lot of interventions. We do have a lot of protocols, guidelines, these gold standards out there. And Barbara, you touched on that as well. A lot that has been put out there by the CDC and the Joint Commission. But it sounds like those issues that you're describing as this creation of this new sort of pocket of opioid abuse isn't really touched on by these protocols. How are you guys in your own organizations, what are the challenges regarding the practicality of actually deploying those standards, those gold standards, to actually target these challenges that you're seeing and experiencing?
Heather, it is challenging. I think, one, it's a challenge to even understand all of the requirements. So I know, as you mentioned, Joint Commission has come out with a lot of new standards on pain management that are effective in about a month. So just understanding what hospitals are now required to do, it's a lot. I think we've been doing some of it, but to raise the bar and make sure that every patient is assessed for pain and all of the staff are educated, and we go through all of our order sets that are pre-built, and we have to revise those and change our prescribing habits so that the opioids are not our first line all the time, that we're really limiting short courses and low doses as much as possible. There's a lot of prescribers in the hospital, so trying to reach out to everyone is a challenge. And then certain laws and regulations, we're required to dispense a naloxone prescription or hand out a naloxone prescription to patients who are at high risk of opioid overdose. So trying to identify those patients in a consistent manner. We're using our electronic medical record as much as possible to streamline these processes. We've built an opioid conversion calculator to figure out on discharge, how many MMEs that your prescription has, and will it require prior authorization. Even screening for pain and high-risk patients, we've tried to build those in to our electronic medical record so that people don't have to rely on their memory, or we have standard tools in place. I think it's a challenge, depending on the size of your hospital too, and your emergency department, to have 24/7 resources in place. We have some peer recovery coaches. We have substance abuse consult services, but these staff aren't always here 24/7 to meet the needs of people. I mentioned too, is it enough to just give someone a naloxone prescription? What that means, they have to go to the pharmacy, they have to fill it, they have to pay for it. Are they going to do that? And what's our obligation? Is it really enough to give them a prescription? Should we be giving them the drug? So we are trying to do that. We did receive some donations from our state of Maryland. They're just about out now. So when that runs out, how will we provide the antidote or the rescue meds to these people? We've implemented a meds to beds program so we can try to get, and we have some to-go naloxone in our emergency department, really trying to restrict it to people who are self-pay, so we can give them something if they can't afford it. There's a lot of products out there for naloxone, so trying to figure out one you're going to prescribe. Of course, you have the vial that requires the needles and syringes, and then the nasal spray, and then the pre-filled naloxone syringe with the atomizer, which we think is our most common product that we want to give out is about $32 for 2 doses. But it's a lot. It's a lot to work through. We have an opioid task force, a multidisciplinary task force that meets every 2 weeks as we're trying to meet all the goals for January 1.
Thanks, Barbara. Dave, can you speak a little bit to those challenges about deploying the standards and protocols that we see out there within your organization?
Well, again, we're trying many of the same things Barbara mentioned, but frankly, with far less resources. Currently, we have no addiction specialists in our 900-bed hospital system, which is a challenge. We clearly don't have 24/7 coverage by services, including social workers, which tend to be involved highly in it. We have one somewhat of an advantage, which is West Virginia was very big in signing in with the Medicaid expansion. So most people have some form of insurance in West Virginia. So they theoretically have access if they're given prescriptions like for naloxone. It's not clear in my mind how effective it is, as Barbara mentioned, in giving those prescriptions out versus providing the medication. And we just were given a large amount of medication by one of the pharmaceutical companies where we will be given them statewide about 800 doses of the nasal naloxone. And so and figuring out a delivery system of do you put that in the hands of the patients, or do you put it in the hands of first responders, police, firefighters, and EMS? So a lot of those challenges. We've done many of the same things in terms of working on our order sets to be a little more appropriate, but that's a challenge because so many of the changes we are making make sense for the drug-naive, opiate-naive patient, but they don't address the pain needs of the opiate-addicted patients, which are incredibly difficult to meet, especially when you think some of the treatment alternatives like non-steroidal medications are often contraindicated in patients like our laboring pregnant women, our post-surgical patients. The patients that are on therapy with, say, Suboxone or Subutex, they're also very difficult to manage their acute pain. So a lot of challenges, as Barbara mentioned, just understanding the regulation changes is difficult, but more than that, spreading that to a very large nursing and medical staff is a challenge.
Thank you, Dave. Yeah, that's a really important perspective. Heather, can you speak a little bit to this from the risk perspective?
I think to build on what both Dave and Barbara have said, there is so much out there that remembering it all and understanding it all, and, and from a risk management side of things within the organization, you become part of that enforcement to making sure that these things are being done and sort of having to help with that culture shift and change and understanding that you sort of have to change your approach and the prescribing habits. There's now some mandates for education for clinicians so that they really understand the difference between your long-acting opioid versus, some of the others, and also keeping track if they're meeting the requirements. If you're in a state where you do have this mandatory monitoring or querying of the PDMP, how are you keeping track of that? How are you making sure it's been documented? How are you supporting that you're doing the right thing so that if later down the road there is a bad event, you can say that you did everything you could? The protocol for handling patients, both the naive, the new who are getting the opiate for the first time because maybe they've had a procedure versus those who are, have the opioid disorder, and sort of how do you manage the risk around that, because you cannot obviously force people to do what you might feel as a practitioner is the safest and right thing to do. I mean, it's always a challenge for us in healthcare, right? A lot of the guidelines that are out there, I think the problem with that is that while they're important and good and are going to help with folks organizing themselves and beginning to approach the issue, I think they're very specific, and they may end up in the long run creating a standard of care for the plaintiff attorneys to be able to use. So how do you balance, just taking care of the patient and doing the right thing, and yet you still have to keep your arms around all of this? And I think it's a big job. You have so many prescribers within the organization and the clinics, and I mean, it's widespread, and the resources, even for risk management, are very low. So obviously education is a big piece of that, but that's always a challenge too.
So this is Tom. A question really for all the panelists. So here's what I'm hearing. I'm hearing that there are obviously a lot of attention. This is a problem that's not going to go away, right? There are some resources that include funding, that include some of the community stakeholders like pharmaceutical companies. I'm wondering if we can push this concept of community partnership a little further. And certainly there are some willing to help potentially challenges with others, but would seem to me that this is a national crisis. We just saw the commission report come out earlier this year on opioids, and what does it look like, number one, realistically, number two, all barriers aside, what's it look like when the community gets more involved, and what sort of partnerships need to happen? Yes, we know some are formed, right? But let's push this further. What's that look like? What's that feel like? And we can keep the same pecking order here with Barbara, then Dave, then Heather. But if we're looking at other community partnerships, we can't do this without that, right? So in our own institutions, we cannot solve this. It's just way beyond that, right? You've already got a patient population that is not going to be compliant with most things we tell them. They're going to want to use, they're going to find ways to use regardless of prescriptions or not. But so we need the community, right? What's that look like? Let's push that further. And so the question is just that. What's the community need to do with us and for us in terms of helping solve the crisis?
That's a big question, Tom. This is Barbara. I know that we are actively working and meeting with the Maryland Hospital Association, the Department of Health, because there's so many challenges in terms of the different types of requirements. We're trying to streamline and have one prior authorization form for the state of Maryland. So we're working with them because it's hard for us to work with each managed care organization separately, and so we're working with those bigger organizations, Maryland Hospital Association and Department of Health. We are providing resources to our patients for treatment programs and resources for them. But in terms of, I guess, it would be nice to have a better link to those places for the patients, trying to get the treatment scheduled while they're in the hospital and follow up with that patient. I think with the access of patient information, I think we have to work together to give as much access as we can without compromising the patient's rights. So that's another challenge.
This is Dave. Well, we have done very little with the community other than education. So people are much more aware of the problem, and they are aware of what to do in the case of a suspected overdose. But to really involve the community in a robust way requires funding that just does not exist. There essentially is almost no treatment options in West Virginia. The number of even outpatient programs is very small. They could only reach small number of patients. So we are doing the best we can. We're addressing some of the issues, such as we have developed pretty robust needle exchange programs for heroin addicts. But in terms of actually doing things to help us decrease the number of opiate addicts and provide the needed resources and for them, we just don't have the financial ability to do it. We're spending so much money just dealing with the costs of our current opiate addicts that just from a medical perspective, the hospitals, the EMS agencies do not have additional resources to put to dealing with trying to lessen the problem.
Yeah.
I think, obviously, Dave mentioned education and Barbara as well, even within our own communities, making sure that we're starting that I think at the high school level or younger with some awareness and understanding of what addiction means, how easily it can happen. A big population of this, unfortunately, is your teens and your early 20s. It's easily accessible oftentimes within the parents' cabinets. They have the give the drug back days in a lot of these communities, and I'm sure that helps. But do people really understand why they're doing it? I would say that they don't. I think, also beyond the hospital, what about the dentist and your podiatrist and other folks who aren't as connected to the organization and their understanding and requirements when it comes to the prescription? We just actually had this debate in my own home. My husband's a medical professional. I've got my son who's going to get his wisdoms out. And of course, I'm worried about the medication that he's going to get after the procedure, but yet we need to control his pain. And we had two different schools of thought, even the two of us in the same house, about how we would manage that to keep him safe, because oftentimes the prescription they give you is way more than you need. But it's also the education, right? And so not everyone who even works in the health system, let alone the community, is understanding. So I also think a piece of this is the drug companies and their advertising and the way they've marketed it. If you look back at a lot of the reports out there, as the chronic pain treatment for non-cancer and things of that started to grow and the push was to address that, you can see that the drug companies jumped on board with this and really pushed, obviously, the use of theirs. And I think we need to partner with them as well in really being more, more transparent about this, even though they're obviously the ones, we need the medicine. So, but I think that they need to be part of solving the problem, and they certainly have the money to be able to do this, so.
If I could follow up on Heather's comments, I think we all should be very clear on a couple points. One, we created this problem. The pharmaceutical companies clearly were pushing opiates for chronic pain management in a very, very big way. Providers, physicians especially, were enablers and went along with this approach and prescribed in very non-evidence-based ways. And we created a huge pool of opiate-addicted patients. And now our biggest push seems to be making it more difficult to get prescribed opiates. And it's a good goal. But when you don't tie it with the ability to do something with your current addicts, it is a problem we cannot win. We're losing this battle, and we're losing it badly.
stay on that. Yeah.
Exactly. I agree, Dave.
Yeah. I've heard, Barbara, you've done a lot at University of Maryland regarding this. When your organization started to approach this problem, can you talk a little bit about the details of sort of how you guys even began that journey and how you started designing programs around this problem?
Sure. So we met at a senior leadership level. I was included in that discussion in terms of who is going to own this, where and how will we bring a group together. So that conversation happened, and we created an opioid task force. It's a large group. We have subcommittees of that group. So the chair is our medical director for ambulatory services, and there's a lot of physicians with different service lines. Of course, we have shock trauma, we have ambulatory, internal medicine, surgery, oncology, family medicine, and we have some pharmacy representatives. We have other disciplines, social work, and whatnot. So everyone comes together. We have a gap analysis that we did. So we looked at the requirements, the legal requirements, as well as the Joint Commission requirements. We went through each one. We scored ourselves and identified where our gaps are. And then we action planned around each one. We determined, how are we going to address this? We have subcommittees, as I mentioned. We have a subcommittee on policy. So what new policies do we need? What new protocols do we need? We actually had to submit protocols to the state of Maryland, certain time frames within the last several months, and another one on January 1st. So we needed to have guidelines on prescribing naloxone discharge for patients who came in with an overdose and things like that. So going through developing a timeline for everything to make sure we met our deadlines. Like I said, we meet, the big group meets every other week. We have subcommittee meetings in between. We have a committee that looks at processes for inpatient and outpatient. So we have two separate committees. So how are we going to implement our new processes? We have a subcommittee just for the electronic medical record. We have Epic here. How can we use our electronic medical record to force compliance? So going through, just number one, assessment of pain, standardizing tools, looking at researching what's the best practice for screening and identifying high-risk patients. How do we want to build? We want to build our discharge naloxone prescription so that it's easy to find and streamlined. We also include our non-pharmacologic treatments. So we have providers, we offer consults, we have all kinds of things that as a pharmacist, I didn't really appreciate all of the non-pharmacologic treatments that we offer. But again, the resources are limited, and we have about 700 inpatients plus our ED and everything. So, and our clinics. So how do we reach all these people with our service and our specialists, including our pain management specialists and substance use counselors? So it's a lot of work. We've been working on this probably since the spring. So, and mostly it started because of the mandates through regulation. So it's a lot of work. We're still working. We're still trying to improve. And we've also identified some metrics. So one of the Joint Commission requirements is to identify some metrics to monitor how effective have your interventions been and have you made a difference. So developing the metrics, I can mention a couple of these. We're looking at compliance to completion of our pain assessment tool. That's a report that we can run through our medical record. We're looking at the use of naloxone as a rescue med. How often are we giving that? The number of opioid prescriptions that are generated monthly because they go through our electronic medical record. And how many of those are greater than 50 morphine milligram equivalents per day? How many are greater than 90? We can filter our report by prescriber, by service or department to see if there's opportunities in certain departments. Obviously, some will be greater than others. Looking at compliance with prescribing naloxone at discharge for patients who meet criteria. So we don't have all of these reports built. We're working on that, but I think it's going to be a work in progress for some time, but we'll continue to work through it as best we can.
Thank you, Barbara. Dave, you actually have a lot of experience and insight with the EMS side of this issue. Can you speak to those particular challenges that you've seen and experienced, how you and CAMC started to approach problems there that you were seeing, and what you and your organization are actually currently doing to actually target those identified issues?
Well, yeah, I am the state medical director for critical care transport, but I'm also our local Kanawha County, my county's medical director for our ambulance authority. Yeah, the challenges with EMS are, again, tend to be resource-based. This year, we expect to administer in my county alone over 1,000 doses of naloxone for overdoses. One of the issues is when you reverse a overdose, you often put the patients in withdrawal, are not very happy campers, so we have had an increase in assaults on our EMS personnel. 60% of our overdoses after you treat them with naloxone refuse transport. One of the issues with EMS is you don't get paid anything if you don't transport the patient. So not only do we have the issue of tying up our EMS, our ambulances with overdose patients, many of them we don't transport. We're getting no reimbursement for it. The cost of naloxone has actually gone up over the last few years. This year, we expect to have about $250,000 in uncompensated care in terms of dealing with overdoses alone. So there's just on the EMS side of things, we are frankly struggling. Again, as I mentioned, we do have some recent donation of 800,000 doses of naloxone, which will help a bit, but of our $250,000 of uncompensated care, probably only $40,000 of that is for drug costs. The rest is for other things related to, things at the time of for EMS response times where we have to bring on additional squads because of this, just our real costs in terms of gasoline and maintenance, our other supplies like IVs and other medications. So EMS across the country is really struggling with this.
Thank you, Dave. It's really interesting perspective, and I think that's something that we don't often talk about or hear about. So I think it's important to look at this issue from every perspective. I'd like to pose a question to those on the call. Are these challenges and these issues that Dave, Barbara, and Heather are talking about, are they resonating with you all? Have you had similar experiences within your organizations, or are there different barriers that you're experiencing, or even are there different interventions that you've seen work for some of these challenges and barriers that we've talked about today so far?
And again, you can raise your hand or submit it with the chat function. We'd really like to hear, since we have an audience from across the country, I think we're all in this one together, as we talked about in the beginning, and this is a major thing that it's not even just healthcare needs to address it. So, is there anyone who'd like to share? Yes.
This is Tom again. So, we again, another topic we touched on is the idea of different payers and the insurance industry as potentially, maybe one of those, for lack of better terms, partnership. I'm wondering if any of you can speak to that side of things. And there was debate. I had mentioned the Opioid Commission report that was released this year and that had received some heat because of its inattention to funding. So, but there's discussion of what about insurance payers? What does it mean for those people? So I don't know if that's something that you all come across or if there's any ideas there. But so the question is how could the insurance companies who maybe do have money, how could they help? How could they be involved as far as trying to tackle some of the more immediate and chronic and later the chronic crises with opioids?
This is Barbara. So our outpatient pharmacies work very closely with our payers, obviously, and we have to make sure before we dispense that we have the authorization by the payer to dispense the prescription. So there are obviously challenges with that, and we're in constant communication with them regarding the prior authorizations, and they have given us some leniency, I guess, and there are some pharmacist discretion. There's some pharmacist discretion that can be used in certain cases to give patients a small supply until we can work through some paperwork issues. So some of them have been amenable to working with us, and our state regulations do support that. I'm not sure how long we'll have the ability to have some clinical judgment about dispensing a few doses, but we do right now. I'm not sure if there's going to be a limit on the number of naloxone products that will be covered in a certain time frame. How many times can someone get their naloxone, once a week? We don't know. I mean, we're just trying to figure that out now, but for now we haven't had any problems with paying for that or covering the naloxone. There are, for our patient population, it's a challenge. We're a level 1 trauma center, so that's not an exclusion. Sometimes we have patients with cancer or palliative care or sickle cell that we've been giving them our patient lists so that they know ahead of time that these patients will get the approval. But a lot of our trauma patients, they're not even considering those kinds of patients with multiple fractures and things like that. So it is still a challenge, but we're trying to work through.
There's many ways that the insurers can help, but they currently aren't helping. Many of them do not pay at all for any kind of inpatient rehabilitation, and many limit or don't pay for outpatient rehabilitation. So those are areas, if they truly were partnering and part of the community, where they do need to step up. Our pharmaceutical companies could do so much more. One, they could stop raising the price of life-saving drugs like naloxone. A self-injector that used to cost about $500 now costs as much as $1,500 to $2,000 for one injector of self-administrated naloxone. So obviously that's not a practical solution. So there are ways they can partner. I just have not seen them stepping up to do so.
Okay, great comments. Thank you guys for that. Okay, So we actually have a couple of questions. I did see one on insurance. I hope that covered at least a little bit of that, but there are a couple of questions that are coming in from the audience. So we're gonna move to those now. We have just a little bit more time here, so we're gonna try to tackle some of the questions specific from the audience. So hang tight 1 second, Barbara, David, Heather, and we'll get some questions to you guys. Okay, so we'll call you out by name there, and you can go ahead, and we'll take you off mute, and you can ask your question. So the first question is coming from Ramesh. You are unmuted. You can go ahead and ask your question.
The question is about law enforcement. What routes besides injection are available for delivery of naloxone?
In West Virginia, we have a program actually where we train both police and fire departments in terms of administration of naloxone, and that is through the nasal route, which is very effective, easy to administer, and still readily available. So we have a very formal program for training. And it is actually in many ways preferred by them because it doesn't involve a needle in the accidental needle sticks.
Mm-hmm. We're using the intranasal naloxone as well.
Mm-hmm.
Okay, I'm going to unmute Robert. Just give me a second. Robert Morton, if you would like to ask your question now.
Yes, thank you. It seems every week there's more medical literature that seems to be changing and evolving the standard on prescribing opioids, like after surgery, and the recent article in the ER setting. And my question is, how much is that impacting the standard of care at this point? Does it put the CDC guidelines that came out in 2016, in the far distant rearview mirror? Can you all comment on that?
What I can say is, one, West Virginia requires mandatory opiate education of physicians. And so that education includes how to appropriately prescribe opiates. And so it has certainly impacted how providers have been prescribing opiates. Unfortunately, unlike I think Barbara has some ability to monitor that, we haven't had an ability to robustly monitor compliance with some of the new current changes in opiate prescribing habits.
Yep. And I go ahead, Barbara.
Well, I was just going to say we're just building our reports now, so it will be very interesting to see, how prescribing changes and also the impact on pain management from a patient's point of view. It's still, I guess, to be determined.
And, with all these toolkits coming out, the AHA just put out a very big one, a big statement that came out in October, a whole, packet of information and guidelines. I think from a risk side, with all of these different ones being available, that actually probably, when you're thinking about liability, whether that's civil or criminal or malpractice, I think that actually gives you more wiggle room, to be honest, because then there's not just one gold standard out there, and therefore can be argued from the defense side as well as the plaintiff side. So, and until there's data and studies done to sort of support certain areas, all we have are guidelines then.
And is the one you just mentioned, was that AHA?
Yes, and actually with the handouts, I think the handouts that I've done, that we've got here, which we can certainly, if you'd like a copy, let us know. I have a link to it here, so it's www.health, no, that's not it, sorry. Anyway, I do have it, so in one of my resources. So certainly just follow up with me at the end of the presentation, folks, and I'd be happy to send you the link.
Thank you.
You're welcome. Okay, the next one is, all right, Elaine. Give me a second to find you. Sorry, it takes a little bit to pull you up so I can unmute you. So Elaine, if you're still on the call and you wanted to go ahead and ask your question. All right.
Yeah. I just had a couple of questions. I actually posted it up on the computer here. One of the things was we were converting to Epic in April, and I wondered if anybody knew if Epic had a screening tool built in for those at high risk, and if not, if someone can share the tool that they have. And I also had a question of what non-pharmacological interventions that others have found successful for inpatients and ER patients. I'm from a small critical access hospital, and we don't have a lot of resources in our community. And so, just trying to see what we can do here with what we have and make the most of what we have. Just wondered, if anybody else had similar challenges as well with that, and how they were able to address this issue, coming from a small community. So sorry, it was multiple questions.
Perfect. Good.
Does anyone?
This is Barbara. I would reach out to Epic to see what they have. I can share ours, after the call today too. But I'm not sure what they have, but they can tell you. Non-pharmacologic treatments. We have all kinds of things from like meditation, deep breathing, acupuncture, massage therapy, music therapy. We have a whole, program of all kinds of things, art therapy for children.
Mm-hmm.
Anybody? Dave, anything else?
I wish I did, but no,
Definitely a challenge.
offer on this question.
And it would be nice if payers would support some of these things too.
Yeah.
All right,
So let's do this. We have about two interim. Let's take one more question. There is a litany of questions. Obviously, this is a hot topic, but what we can do is, and Dave, Barbara, Heather, I'll speak for you here. But if there are additional questions, or hopefully there's an opportunity to share resources, such as the last question about what can we build in terms of EMR support and that sort of thing. We will do a follow-up too. We'll share materials, and if there are additional questions, we'll try our best to get responses out to you all. So,
Shaquila.
Okay, so we'll do one more question here, and then we'll do a quick wrap up. No, we're running short on time here. So.
Okay. Hello, this is Shaquila. I currently work as a regulatory coordinator within my system, and we did the same approach that you guys were talking about as far as like a gap analysis and devising a team to look at these new regulations. And one of the components we were looking at is where it says the hospital provides information to staff and licensed independent practitioners on available services for consultations and referrals. We're running into kind of like an obstacle because we don't have a pain management specialist within the hospital. So I have care management director also looking at that as well. But any instances or any best practices as far as consultations and referrals for patients?
This is Barbara. I mean, we try to collect what's available in the community as well. And we are putting together a resource that will on our intranet page of what's available in the community to provide to patients at discharge as well as to our healthcare providers.
Okay.
I think too, education for your providers and knowing when to refer and not holding on too long, and really understanding what pain management specialists can provide that are non-pharmacologic as well. If you've never been to one, you have no idea like all the other possibilities actually that are available, and their approach to it is very different, even if they have to use it with the opioid or not. And it can be used for so many different types of acute and chronic pain. I think that they're an underutilized area. So I think educating your primary care and family care doctors and your surgeons, your especially like your orthopedic ones, because they're a big proponent of prescribing opioids and giving a lot of it, and not really managing the pain per se. So I think starting there is also helpful. Because if you look at it from a risk management perspective, if you hold on to them too long and you sort of manage it outside of your understanding and scope, obviously that does put you at some risk on, liability issues.
Okay. Thank you.
And actually, we're going to take one more because, hold on, Jody, if you're still there. I think. All right, Jody, go for it.
Hello. Hi. Yeah, I was just wondering, does anybody have experience or could share if they have provider satisfaction surveys, say they're the provider PQRS score or MIP score, have you noticed an improvement by if you've implemented a policy in place focus so that the policy would focus around your pain management, focus more towards this is our facility's policy than to, make it look like the provider is picking on the patient. So I'm just saying individually those providers, does anybody have any data or can say yes, their scores have improved because they have a clinic policy in place around that?
We do not at this time.
We do not, and our providers believe that their personal scores are actually getting worse now that they're adhering to better prescribing practices.
Interesting. That's a challenge. Yeah.
Is there anyone in the audience who'd like to comment on that before we close?
Yeah.
It's almost like then the next step would have in that common language for the providers to say, kind of empathize with the patient and say, well, this, we're sure sorry, but it is our system policy, takes it out of my hands, and as an employee, I have to follow that. I kind of wondered, in North Dakota, we don't have that across our state either. We have a few clinics in the northwest pocket of our state that are having some success, and we're going to look at this a little bit deeper. But I thought if anybody on the call has done it, I'd love to visit with you.
Good question.
Thank you, Jody.
Thank you.
Well, in closing, I think we all realize after listening to this discussion and being part of it today that knowledge alone is not sufficient to address the challenge of the opioid epidemic. The capacity and the commitment from all sectors to support the treatment is essential, and we've talked about that. And in addition to improving opioid prescribing practices, expanding access to assisted treatment is paramount here. While we can continue to maybe prevent some of the opiate naive from getting addicted, we still have this bigger problem of the folks who are already part of the system. The most important rate limiting factor in response to the opioid disorder is the ability to access treatment. We talked a lot about that today. The range of services that have been proven to be to work in different circumstances, and the availability of those clinicians is not there. They don't have the necessary authority to provide that medication-assisted treatment. So these efforts are going to require access capacity and level of communication that does not currently exist, and it has to stem within the community as well. We really have to have sort of a call to action and trying to get everyone on board and understanding the depth of this crisis beyond just the few articles that the general public probably sees. It's just sort of the beginning. We're also seeing out there that the ONC is working with health IT and PDMPs to try to find ways to address the important challenge, making this more accessible to providers, making it more efficient, creating alerts, and they've done a bunch of pilot studies, and their reports are available. The Carolinas healthcare system is researching and implementing new methods to influence the prescribing practices and integrating it, and how can they use their electronic systems, which we touched on a little bit today. Like the EHRs need to be integrated with these PDMPs so that it's not me going to another website to check it and it's spinning and spinning and I can't get in. Well, then what is the success rate? We're demanding that these folks, have to check it, and then they can't because they're busy practitioners, and it can't wait 5 minutes to try to find this out. So we still have a lot of, technical issues as well. This is just the beginning, obviously. We need to continue to raise that awareness and challenge the prescribing patterns and really work. And there are plenty of stories out there showing that there can be a decrease in the prescriptions being prescribed, but we can't forget about the community that, that's obviously addicted and been suffering for a while. I thank you very much, Barbara and Dave, for participating and for the audience for speaking up. This was a great discussion.